in your wonderful country. Actually, I arrived yesterday morning and I spent a wonderful day at Vilnius, so thank you very much for this. And as a matter of fact, I listened to the previous talk and I realized that you are facing pretty much similar problems as we do. And also I realized once more that Greece is the champions. We hope that we will win champions in basketball soon, but by definition, in basketball you may be a champion for 1 year, but not for the other year. By definition, in terms of antimicrobial resistance, we are the champions. And as a chairman of the European Sepsis Alliance, I have devoted the last 10 years of my research in trying to investigate how I can deal with the major driver of resistance, which is taking place in winter, which is taking place a bit in autumn and a bit in spring. Viral infections, viral respiratory infections. How can we find the strength? How can we find the courage not to give antibiotics to these patients? So allow me to move on with my conflict of interest disclosure and allow me to bring you to a very common scenario. So you see an X-ray which is pretty much normal. But the X-ray belongs to a patient who's arriving at the emergency department. He's suffering from chronic obstructive pulmonary disorder. The patient has cough. He has a bit of pulmonary sputum, and the question is, what can I do to this patient? So, how many of you, no other symptoms, no fever, no dyspnea, no physical signs, would say, let him go home, I need your help? How many would you raise your hand and say, discharge him home? Okay. How many you raise your hand and you say, give him clarithromycin or doxycycline, as you mentioned earlier on, and send him home, the third option? How many would you say watchful waiting? Okay. So you would say to your patient, go home, or leave him a bit at the emergency department, and if it's stable, he goes home. If not, we write antimicrobials. So that means that not many of you would choose to any of the above. Okay. Allow me to move to something which is much more difficult. A patient who's relatively well. Imagine that is the previous patient. He appears well. Allow me to bring it in a different position. I remember 3 years ago, the pandemic starts, and all of a sudden, there are a lot of patients arrive at the zoo, and as they arrive at the emergencies, we give priority to those with dyspnea, to those with high fever, and the rest, we send them home. And all of a sudden, at the very beginning, the Alpha variant, many of them were coming back in the evening. They were even come at night, and they were dyspnoic, and there was a need of mechanical ventilation. And the time difference between the first and the second visit was just 10 hours. All of us have experienced that. And you know very well that there is a bacterium out there which is called pneumococcus. And it's causing exactly the same thing. So, I would like to give you 3 scenarios. For a patient who appears relatively calm, relatively mild, no worries for him. So, first scenario, PCT is 0.29, procalcitonin, and Presepsino is 500. And I give you 3 options. First option, give him clarithromycin and discharge him home, doxycycline. Give intravenous meropenem and administer at hospital. Third option, all these are crazy things. The patient is doing well. So, how many would you give doxycycline and discharge home? How many would bring him to hospital and give intravenous meropenem? How many believe that I'm nuts? So that means that all of you realize that the biomarkers are abnormal, but the patient is phenomenally well. That means that we need to move. If we are to choose the choice 2, which is the correct one, by the way, a bit above the tradition. As you have seen at my disclosure, I'm professor in the medical faculty. And I know very well that this Monday, I have to go to my students and tell them, first of all, history, medical history. Second of all, physical science. And I know inside my heart that technology, research, is moving us towards a completely different field. Why? Because for all diseases, and you know what very well, which is the major disease where this is taking place, it's not an infection, but it's cancer. For cancer, what you do, you say to someone, do cancer biomarkers, measure PSA, because what we have in the back of our minds is that even if PSA is increased, we have time in front of us to tell to the patient, go for ultrasound, go for biopsy. And we know that just because a biomarker is increased, a tumor marker is increased, the time is not against us. But in the case of infections, we are working against the clock. Do you like to see your patient cyanotic? Would you like to see your patient dyspnoic? Would you like to see your patient admitted in the ICU to do something? COVID-19 taught that to us. We have to act fast. And unfortunately, with infectious diseases, when we have signs, particularly when it comes to respiratory tract infections, it's already too late. Second option, procalcitonin is 0.3 and Presepsin is 70. So allow me to give you some options there. First option, again, clarithromycin and discharge home, meropenem and hospital admission. All the above are crazy. So, who could bring the patient inside the zoo for intravenous meropenem? You understood that zoo is the hospital. You know that, you are physicians, so it's indeed a mad situation, particularly the emergencies. Who could just say, give antibiotics and send the patient home? I hope that I will convince you by the end of my talk that option 1 is the correct thing to do. And then final option, procalcitonin is normal and Presepsin is increased. Again, the same options. So, that's the big problem. When sepsis 3 definitions were developed in February 2016, the idea was, I think now that I can move on and continue my presentation from there, when the new sepsis 3 definitions were developed, the idea is that we want to know how much of a problem we have. And in order to realize how much of a problem we have, we were in need from each and every country to go hospital by hospital and to see how many patients they develop the new sepsis 3 definitions. This is the map of the world. This is a publication of February 2020 in The Lancet. And you see that the more deep blue you have, the more sepsis you get. And it's really striking that in 1 year, you get 50 new million cases of sepsis, and 25% of them die. How can we reduce death? We know that very well. This is a retrospective analysis of 2,713 patients with septic shock from Manitoba, Canada. And the patients are classified into those who started early antibiotics. That means not antibiotics were prescribed, antibiotics were administered in the vein. That's the real problem in the emergencies. You shout, and in the very end, you prescribe something, and from the time you prescribe something until this is administered, it may get some hours. I see smiles in the audience. I'm happy, because this is the situation everywhere in the world. We just don't dare to say it. Emergencies means pain for the patient and pain for us. And what I've been taught all these years working in the emergency is that the real urgent cases arrives when you are exhausted, at midnight, at 2 a.m., at 3 a.m. So if you give immediately antibiotics, then the patient will survive with a chance of 80%, but for every hour of delay of the administration of antibiotics, you increase the relative risk of death by 7.6%. But how do you know that you give the correct antibiotics? And let's say that we give antibiotics to everyone. Can we bring harm? So the silent disaster. This is a patient of 60. He gets antibiotics for viral infection just because the physician cannot say to him, no, you will not get antibiotics. Actually, you know, the patients are pushing for antibiotics. It's not us. The patient, they ask for something. They say, you will give me just vitamins and rest. So look what happens to the patient. What you see there is the colon, and what you see in bricks in red is the normal flora, and a single shot of antibiotics, a single shot, destroys 10 to the 3rd degrees the normal flora. But even one can be resistant, and it replicates. And then what you have as ecological remnant is fully covered very fast by resistant microorganisms. I always like when I teach my students and I show them this graph, then immediately I ask them, do you believe me? And actually I want them to say, no, I don't believe you. Why? Because there is no reference there. You are just acting, and you have just drawn a wonderful cartoon. But where is the reference for that? Because we are in the period and in the era of evidence. And evidence is coming only through randomized clinical trials. And in order to prove that, we are not in need of a randomized clinical trial in patients. We need to randomize healthy volunteers, which is actually something which took place. It was published 16 years ago in The Lancet, and it was funded not by the industry, because it's obvious that the industry would never fund such type of trial in healthy, but it was funded by the European Union. So healthy volunteers, they were randomized to a full 7-day course of treatment with clarithromycin or a full 3-day course of treatment with azithromycin, and they got also respective placebo treatment. What was the idea? That as the time went on, I get samples from the gut flora and I look for resistant bacteria. Look at the results. That's impressive. 8 days. Still impressive, day 14. Still impressive after 1 month. Still impressive by day 42. And still impressive by day 180. So, based on this publication, oh, I apologize. Can I go back? Yes. Based on this publication, there was a guidance that you should never give empirically the antibiotic that you have given to the patient the last 3 months. But always a coin has a double face. The one face here is that if you give antibiotics, you induce resistance. What is the other face? That there is a stable resistance in the placebo group. That means all of us who are here, and all of people who are not physicians and who are stepping outside, we have in our gut resistant bacteria. So what you do by giving antibiotics, you kill the susceptible one and you allow room for the resistance to grow. And how resistance comes? But from food. Because quinolones are the best growers if you feed animals for meat. And the same is the case for glycopeptides. So, what bacteria do once they enter our body? You know that bacteria are gram-negative and gram-positive. And the gram-negative bacteria, they multiply, and as they multiply and they replicate, they release their endotoxins. The gram-positive cocci, they release substance of their peptidoglycan, which is the cell wall of gram-negative bacteria, and all of a sudden endotoxins, they bind on TLR4, peptidoglycan on TLR2, but also even the bacterial DNA can bind to TLR9. And once this is taking place, all of a sudden there is a series of intracellular activators, which leads to the activation of NF-kappa beta, and NF-kappa beta is a promoter of the transcription of genes of cytokines, and the cytokines, they orchestrate fever, tachypnea, tachycardia, vasodilation, neutrophilia, and organ dysfunction. And then the question comes. All this is taking place before the patient comes to you. And the question is, if this took place before the patient came to me, can I find in his blood a signature that this took over? Between the TLR receptors, there is a protein which is called CD14. Once the macrophage is under this production of cytokines, and once the patient arrives to you, this is CD14 becomes soluble and binds to gram-negative and gram-positive. So if you can measure soluble CD14 in the blood, that means that this reaction took place and that your patient is septic. What's the name of the soluble CD14? Presepsin. And let's see if this is indeed real and if the kinetics of Presepsin are better than the other inflammatory mediators. This is the famous human endotoxemia model, which is done in the Netherlands, and these are 10 healthy people. They are intravenously induced, given 2 different doses of endotoxins, and we measure, as the time goes on, the area under the curve of the inflammatory mediators. And we compare Presepsin with C-reactive protein, with IL-10, with IL-6, with TNF-alpha. Please note, the axis, the y-axis, showing the concentration is logarithmic. That means that the difference between Presepsin, which you can see in the left, and the rest of the mediators is 100 to 1,000 more. And indeed, when you give LPS, the top mediator which is produced is Presepsin. Then, can we use Presepsin for the diagnosis of sepsis? This is a meta-analysis of trials, comparison with procalcitonin, and measurement of sensitivity and specificity. Allow me to make it a bit more easy. We bring the sensitivity and the specificity of all trials together, and you see that the average sensitivity is 85%, the average specificity is 78%, and compared to the famous meta-analysis of procalcitonin, Presepsin does far better than PCT for the diagnosis of sepsis. Allow me to show you some data of my group, which has recently been published, and I'm really proud for this data because we used three different cohorts of 3 completely different time periods. The first cohort, we call that the derivation cohort. Our patients with QSOFA 1, with different types of infections, most of them lung infections and abdominal infections, they arrived to us, and based on sepsis 3 criteria, we split them into those with sepsis and those without sepsis. And in this cohort, we elaborated a concentration of Presepsin of 350, which is used as a cutoff of diagnosis. Then, once we elaborated this cutoff, the question is, if we bring this cutoff and we put it into 2 different other cohorts, if this will work or not. The first validation cohort was coming from the emergency department. The second validation cohort was for patients with COVID-19. And so the question is, in our patients with validation, 1, we split them into sepsis and no sepsis by sepsis 3, and then we try to see if the cutoff of 350 can indeed demonstrate those who had sepsis. And when we moved to the validation cohort of COVID-19, the question is, if you have high Presepsin, if you will get mechanically ventilated or not. So, this is the 3 cohorts. In blue, the derivation, in orange, validation 1, in gray, validation 2, and you see the comparisons in terms of sensitivity. It is ranging between 80 and 95%, specificity, which is lower, positive predictive value, and negative predictive value. Negative predictive value works like the sensitivity. So, it is a very sensitive biomarker for the diagnosis of sepsis, and is a valuable rule-out biomarker to exclude sepsis. This is what negative predictive value is telling us. But what is driving sepsis? Comorbidities. The CCI that you see there is the score of comorbidities. Type 2 diabetes and COPD. So if indeed Presepsin is diagnostic, in this multivariate logistic regression analysis, it should be completely independent than these 3 for the diagnosis of sepsis. And indeed, it does. If your Presepsin is more than 350, you have a relative risk of 4.5 times more to have sepsis, even if you have comorbidities, even if you suffer by diabetes, even if you suffer by COPD. But sepsis is one option. What sepsis means? An infection with high risk of leading to death. So let's see if this is diagnostic for mortality. Oh, that's huge. More than 90% sensitivity in all cohorts. More than 90% negative predictive value, almost 100% negative predictive value in all 3 cohorts. The perfect rule-out marker. If Presepsin is less than 350, you can safely discharge your patient home. And the question is, how can we be certain about this cutoff? We are the only ones who have developed this cutoff. Let's validate that. Let's see what meta-analysis for a cutoff is teaching. Meta-analysis including 5 observational, 4 retrospective, 2 prospective studies, 2 cross-sectional works, 1 case series, and 1 pooled analysis. And all of them, they point that there is 350 picogram per ml cutoff that we have developed is the correct one. But this is half of the answer. The question that I elaborated at the beginning of my talk was, first of all, if the patient has sepsis. Okay, but the second is, do I have to give antibiotics in case the patient has no sepsis? Before jumping into this, I would like to remind you that all biomarkers are eliminated by the kidneys. So in patients who have a good renal function, the cutoff is the one that we suggested. But if the patient has chronic renal dysfunction, then you need to consider a higher cutoff. Why? Because the patient cannot secrete the biomarker as efficiently. Now let's move to the question of antibiotics. I know very well that the majority of you in this room are working in the emergency field, and I know that great many of you are working in the ICU. But there is one specialty in medicine which is considered to be the specialty of, let's say, the intellectual. And this is endocrinology. It's very difficult to become an endocrinologist. It takes a lot of years, a lot of effort. I did not speak about diabetes. I speak now about the endocrine glands. When someone listens about pro-peptide, all of a sudden we go back to our, let's call it souvenirs of when we were young, that pro means that it's cleaved and an active hormone is secreted. But that is what the researchers, they thought in the very beginning for procalcitonin infections. Because they soon realized that although there was a resemblance to the procalcitonin of the thyroid gland, that was wrong. What is happening with PCT, it is that it is a hormone which resembles the procalcitonin of the thyroid gland. It's not the same thing, but which is secreted in tiny amounts from all cells, all organs of our body when we are infected. So in other terms, what we measure is a total of the stress our tissues and our cells are recognized. So what is the art of endocrinology? To realize that, and allow me to give you an example. It is really bizarre, but you know, in my country, probably the water is not what it should be. And most of us, around 20% of the population, we suffer from hypothyroidism and goiter. I disclose in public that I'm one of those. So when I started getting treatment, they told me, okay, you will get a pill of 100 micro-G per day, and let's measure your TSH. After 1 month, I measure the TSH, and they tell me, oh, it's 3.5. Increase the dose. So I told the endocrinologist, why are you telling me that? 3.5 is within the normal. And he said, no. We endocrinologists, we don't care about the normal. We care about the trend from one measure to the other. So 3.5 means that the production coming from your thyroid cannot cope up with your demands and you need to increase the dose. So in other terms, we need to incorporate the changes into an algorithm which can tell us when to start antibiotics, when to stop antibiotics, and adapt this algorithm to comorbidities. And in this way, we will not introduce harm, we will provide clinical efficacy, but it's high time that the value of a biomarker comes from a randomized clinical trial, not by our belief about things. Because if this is true by a randomized clinical trial, not just one, many of them, then you are obliged to do that for the sake of your patients. So, everything starts with medical history and physical examination, no doubt about that. And if, of course, you believe that the patient is in trouble, you need to act as if the patient is in trouble. But if you don't have evidence, the patient is calm. Or the patient is like the first one that I presented with the COPD, with a bit of sputum, a bit of cough, and nothing else. So apply this rule. If procalcitonin is less than 0.25, not prescribe antibiotics. If it's 0.25 or more, give antibiotics. And how can we know that this is correct? So let's randomize the patients. The patients arrive in the emergencies, and we measure to them procalcitonin. In half, we measure procalcitonin. In the rest, we do what we would do if procalcitonin was not available. In those for which procalcitonin is available, we don't prescribe antibiotics if it's less than 0.25. We prescribe if it's 0.25 or more. Is this possible? Is it possible to run a trial like that? Yes, indeed. And you can even publish that in The Lancet. And if the final diagnosis is community-acquired pneumonia, or exacerbation of COPD, or bronchitis, by using procalcitonin, the amount of prescription of antibiotics go down, even in pneumonia, because many pneumonias are of viral origin. And then someone would say, okay, it's just one trial. I don't believe it. I want to see that taking place even more times. And also I want to be certain that through this approach, the patients are not in risk. So get another 3 trials with the same approach. No risk for death, no risk for the patient, prescription goes down. And then the patient is hospitalized. He's in the ICU. Many of you are ICU physicians with sepsis. He got antibiotics, and he's doing better. That's the nightmare. The nightmare is not if something goes wrong, because by definition you have to act. The nightmare, the patient is improving. Shall I stop medication? Ask yourselves how many times you came across that dilemma. If he gets undertreated, if he relapses, oh, he has that CRP of 40. I will suicide. He has a CRP of 40. The CRP should have been 0 or below 0. You know very well, I see your reaction, what I'm talking about. So, read out his reaction and decide what to do. Which means that you need a stopping rule for antibiotics. So you got the decision to give antibiotics. Before you start giving antibiotics, you measure procalcitonin. And then antibiotics continue. And as antibiotics continue, you repeat procalcitonin, and once some criteria are met, you stop antibiotics. And we have 2 randomized clinical trials suggesting that the stopping rule should be an at least 90% decrease from baseline, or you stop antibiotics when you see that PCT is below 0.1. 3 trials suggesting 80% decrease or PCT less than 0.5, and 2 trials suggesting 90% decrease or PCT more than 0.5. These are the results of these 7 randomized clinical trials. In all, consumption of antibiotics went down, no risk for the patient, no complications. So allow me to tell you, by showing you this publication, that if you don't use PCT to stop antibiotics, you will induce a serious and major harm to your patient, and you will lead him to death. So this is a randomized clinical trial in patients with sepsis, lung infections, or acute pyelonephritis. And we randomized patients into those similar to your patients. Give them antibiotics forever. Don't tell me that I misinterpreted the previous speaker because I had even my headphones. It is exactly as it's happening in my country. And then the other arm, you give antibiotics, and by day 5, day 6, day 7, you measure procalcitonin. On the time when procalcitonin has decreased by 80% or more, or you find procalcitonin less than 0.5, you stop antibiotics. You follow up the patient by day 28 and also for 6 entire months. And meanwhile, you get stool for the patient to see how the gut flora is changing. And we elaborated a peculiar endpoint, an endpoint on how we can destroy our patient by giving him antibiotics for long. In other terms, for 6 months, to have an infection by Clostridioides difficile, or to have infection by multidrug-resistant antibiotics, or if you were enrolled in the trial because of multidrug-resistant antibiotics, you died by them. So this is the time to the event. The 2 curves in blue, those where you give for long antibiotics as we do it daily. With red, I stop with procalcitonin, is the time to the event. The blue curve is well above and towards the left compared to the red, which means that the events are much more frequent and they arrive much more rapidly. The relative protection of the patient by using procalcitonin through this approach is 55%. Why we did that? Because by prolonged administration of antibiotics, the flora, the stool flora, was colonized by multidrug-resistant bacteria and Clostridioides. And what is on the panel is the risk to develop the event. If you become colonized, in blue are patients of the comparators, in red are patients with procalcitonin. The statistical differences are there by day 7, by day 28 from the start of the study. So you have a decrease of colonization of the gut, and of course a decrease of the events. Oh, can you sleep at night by that? If you use procalcitonin, mortality goes down by 54%. Those who were treated for long with antibiotics, these sepsis patients who were treated for long with antibiotics, their mortality was 28.2%, and it went down to 15.2% in the procalcitonin arm. And someone say, why? Okay, I stop early antibiotics, that's obvious. Antibiotics are deleterious. Of course they do. You know what pharmacy means in Greek? We call that pharmakio. But pharmaki is the poison. In other terms, a drug has a double edge. It saves, but it may kill. So more antibiotic-associated diarrhea. Diarrhea in sepsis, more dehydration. Acute kidney injury. Give colistin forever. Give colistin forever. Will he survive from acute kidney injury? But if you use PCT, you know when to stop colistin, and there will be no acute kidney injury. And also there will be no electrolyte disturbances. So, allow me to wrap up a bit. Use Presepsino to evaluate the patient. If it's more than 350 picograms per ml, you can consider early antibiotics because there is sepsis and risk for severe infection. If it's low, the negative predictive value is almost 100%. Send him back home. If procalcitonin is more than 0.25, particularly the patient with the viral or ambiguity for bacterial infection, yes, give him antibiotics. But if you have already started him antibiotics, use the procalcitonin rule to stop them early. Stop them on the day you find PCT drop by 80% or more, or when procalcitonin is below 0.5. You will have a decrease of 28-day mortality and a decrease of antibiotic-associated adverse events. And I showed you the evidence that this is due to colonization of the gut flora. The advantage is that you know that you have two in one. You can have both measurements, you can surrogate the patient, and they are on the same platform. Thank you very much for your attention.